Welcome to the Menopause and Cancer podcast, and welcome back to episode 2 of our hormone replacement therapy after breast cancer series. My name is Danny Binnington. I'm a breast cancer survivor of 10 years. I'm also the host of the Menopause and Cancer podcast and the founder of the Menopause and Cancer not-for-profit organization. I know this is an emotive and also controversial topic, and I'm really happy to have this conversation with you because many people tell us that they feel very much in a void, very much isolated. They don't know where to go for information, and many feel that they're being shut down from even having the conversation in the first place. Now, I don't even think it is that tricky a conversation to have. We just have to look at the evidence, which we have done last week. And now it's for all of us to figure out how we move forward with the evidence we have. So if you haven't listen to last week's episode, or if you haven't watched it, please go back. Medical oncologist Dr. Leila Agrawal explains all of the studies to date for the use of hormone replacement therapy after breast cancer. On today's episode, I want to bring on Professor Richard Simcock. He's an amazing consultant clinical oncologist at the University Hospitals Sussex NHS Foundation Trust, where he provides clinical care to people with breast cancer. He's also the medical consultant and advisor for our friends at charity Macmillan Cancer Support and an honorary professor at Brighton and Sussex medical schools. And I want to know from him, will there be more evidence for people in my generation for the use of HRT after breast cancer? I also want to ask him, how do you quantify risk? What is the risk exactly that we're talking about? Because no risk is like complete. We know we can increase our risks and decrease our risks of certain things with, from wearing a helmet, cycling, to smoking, to drinking alcohol. How does HRT after breast cancer fit into this? What are the risks we're talking about? And what do we do when the evidence we have is old and not good enough? I want to know from him, how do doctors navigate a really complex conversation and decision-making process like this? Many women tell us that they weren't given the conversation, and I want to talk to him a little bit about communication, shared decision-making, and how to move forward. And also, who holds the risk? Is it the patient, or is it the doctor, or is it both? And so, yes, I'm excited to have this conversation with this brilliant Professor Simcock. I hope you have open ears for this conversation, and let's bring him on. Thank you for being here, Richard, and thank you for your time.
Very, very pleased to be here and fascinated by the work you're doing. It seems so important, and hope we can get this messaging out.
Yeah. So we just had a little bit of a chat prior to pressing record here, and we spoke a little bit about the dilemma we're in. We know what we know, we don't know enough. The data you have is old. I know a lot of doctors aren't happy with the data that you have, but it's what we have. Is there going to be new data for people in my generation?
There won't be the kind of data that we really want right now. The highest standard of clinical evidence comes from the randomized controlled trial. Half of the patients have treatment A, half of the treatments have treatment B, and you monitor them carefully and over many years and see what their outcomes are. Those trials are huge, they're enormous to do, they're expensive to run, and they're not likely to be sensitive to the relatively small changes we see with HRT. The other big problem we have clinical evidence is that the goalposts are moving all the time. The last set of evidence we have on HRT and breast cancer from a randomized controlled trial is over 20 years old. And since then, the landscape of treating breast cancer has changed enormously in terms of the drugs we're using. And of course, at the same time, the HRT that's been available has changed enormously. So you're always running to catch up. So I don't think we'll have the highest quality of standard of evidence. We will get some evidence about newer treatments. It's exciting to see that there are some new anti-breast cancer treatments that are developing which may have fewer hormonal side effects. So we await those, and we will see those, I think, in years, not decades. But in the meantime, we've got people right now who are struggling with their symptoms, and we've got doctors and other healthcare professionals who are perplexed as to how to best help them because there is a void of evidence. And that's what we need to try and resolve. That's where we need to try and find a way forward.
Because we do have a bit of a dilemma. Some of the biggest advances in breast cancer treatment, for example, have been to reduce or remove a woman's estrogen and to suppress that in a woman's body. And no one really ever thought, how can we also help these often very young people in manage that body? And often when people come into our community, they say, I feel I should be doing better. I shouldn't have all these symptoms. My doctor said it was only a little white pill. My whole family celebrated the end of active treatment. I thought tamoxifen was going to be okay. And actually, it's a huge issue. And many people don't last on those treatments because I feel they are unsupported and they were not prepared adequately. So we do have a dilemma. And so I think it's normal that people think, oh my gosh, HRT could just help me.
No, I absolutely agree with you. And if we don't, sometimes we don't have a solution. As in my job as an oncologist, you will know that I will sometimes see people in the saddest and baddest of places with their disease. And I always tell my trainees, never tell a patient there's nothing you can do, because you can give them information and you can give them knowledge. And information and knowledge is power. And if people have bodily autonomy, if they understand what is happening to them, that is helpful. Now, it may not be a solution, it may not solve the problem, but it is an assistance and it is a help. And I think, just picking up on your point there, if we can do better at the outset of a person's experience with cancer in explaining what we are prescribing, why it works in the way it does, what it is supposed to do and how it is doing it, if we can make sure that people are transparently understanding that well, if we can tell them what they might experience, and we can signpost them to the kind of things that might help, particularly non-hormonal therapies, then we've immediately done a great service, which might mean that people aren't instantly straightforwardly looking for, well, is there a magic pill that will save me? So there is a lot more we can do with what we've got in empowering people to have the autonomy to understand and explain what's going on with their own bodies and get them closer to the person that they want to be. And that may not be enough. We may still need to explore what HRT, but we have enough to do better.
Yeah. And I feel that was always the whole purpose of the podcast, because we are over 100 episodes in and we have had probably 98 episodes on non-hormonal prescribable or alternative or complementary options or other healing modalities that, some are more mainstream than others, but whatever is right for me might not be right for another person. So it's really laying it out, everything there is, so that people can pick and choose. And of course, we change over time. The person changes, our needs change, and what might work for me this year might not work for me next year. However, the HRT question, I have felt over the last few years of being in this space, hasn't gone away. In fact, it has had a bit of popularity in the UK, and then there were some conflicting advice from doctors, and it sort of calmed down. Now I'm hearing some louder voices in America with some doctors, practitioners coming forward and discussing. It's the same old, really. We have no new data, no new evidence, but they're discussing the same old story. How can we have uh, maybe a little bit more, not of a compassionate conversation, that sounds stupid, but more of a level-headed conversation where we don't need to say these people are just for HRT after cancer and the other doctors say, no, you can't ever have it, it'll kill you. Like,
Yeah,
how can we have that? Yeah.
It does feel extraordinarily binary, doesn't it? That HRT is the solution to everyone's problems. Take HRT, you'll have a great life, good hair, fabulous sex, and live forever. And the other side of HRT, and the Grim Reaper will come a knocking. And clearly, both of those things cannot be true. The truth will be in the middle, and where the middle is defined will be different for different people. So first of all, we have to accept our ignorance. We have to accept what we don't know and be honest about that on both sides of that debate. Then what we need to do is find the shared space in the middle. And the key word therefore is consensus. So I think we are now at a point, for example, where we can achieve consensus around the use of vaginal estrogen. So that's this. And building from that, we can now start to say, with some medical students at my medical school, we did a survey of some menopause specialists and breast cancer specialists over the last year about the use of HRT after breast cancer. And I expected the result to be, we wouldn't prescribe this, couldn't prescribe that. We presented breast cancer specialists with a number of painted some pen portraits of women at different stages of breast cancer treatment. And we expected the response to be pretty uniform. We would not prescribe this woman HRT. I was really pleased to see that there was a willingness to consider it and an acceptance that it could be helpful. But what also came very strongly through that survey was there's an enormous lack of confidence about what is the right thing to do. So we need to bring people in the middle and find the consensus space. And there is a process for doing that. We're engaged in a process called a Delphic consensus, where experts and specialists gather together, explore the areas of disagreement, and try and find out where the shared space of understanding is, and build out from that, so you can build models and guidelines that help clinicians work to help people. One key part of that is understanding that if we are never able to, let's assume that we don't get a randomized clinical trial that tells us that X is safe, we will always be holding some uncertainty. And I think one of the issues in this, as an observer and a participant in this debate, is who holds the uncertainty? Whose risk is it? And some doctors may have a slightly more paternalistic view that they are not willing to prescribe the HRT because they think the risk is theirs as the prescriber. If there is a risk, that risk is held by the person taking the drug. And it should not. So what we need to do is have a shared decision-making space, whereas as carefully as we possibly can, we can hold that space, and that the person receiving the drug understands that there's uncertainty, understands what the risk might be, and we can talk about the upper bounds and the lower bounds. What's the worst case scenario from this HRT? What's the best case scenario? And that in that shared space, there is a shared decision to take HRT and move forward. Now, if you do that, that does make doctors uncomfortable.
Yeah.
And I know your podcast is for the people affected by these problems. I'm not expecting
Well,
them necessarily to be sympathetic for the poor doctors, but it makes doctors uncomfortable. And when
yeah.
doctors are uncomfortable, they don't necessarily do what they want. So we need to find a way to allow doctors to feel more comfortable with that process. And one way to do that is to build a registry. A
And
registry.
no, I want to talk about that more. Before we talk about the registry, let's just talk about the risk, because it always comes up in conversation with a lot of the women. What is risk? How much is the risk? If I knew my risk was a few percent, like for example, can I take the risk? But because we have this uncertainty, but then a lot of conversations come around, doctors treat people with lung cancer when they've smoked all their year. These people, all their lives, these people clearly increase their risks of lung cancer. They smoked. You're still going to treat them and, respect them as patients. Women then often say and say, they flip it on the head and they say, well, Danny, there is actually no clear evidence. I'm 15 years on from my breast cancer treatment. I've completed my breast cancer treatment. I'm now 15 years on. There is no evidence to show that I've got an increased risk of new cancers in a massive way by going on a low dose of HRT. And no one wants to prescribe it to me. And we don't even have guarantee that there is a risk. So how do you know what I mean? I'm saying
I know
risk.
exactly what you mean.
Risk is so. What is risk? Or for example, I always say that I was cycling without a helmet. Right, that's a huge risk. Other people would
I'll
never
tell you
take
what.
that risk.
Risk is a board game that takes 6 hours and makes you fall out with your family. And when we talk about risk, people talk about risk as it's a single thing.
Yeah.
Risk is, and as you say, if you choose to drive at 35 miles an hour, you're taking an increased risk that you're going to cause an accident. If you drive at 40 miles an hour, so when we talk about risk in breast cancer, I think often people are talking about different things at the same time. So, for example, if you're thinking about risk of HRT and breast cancer, you might simultaneously be thinking about three things at the same time. Will I die of this disease? Will my disease cause mortality? Will my disease come back, recurrence? Or am I, as someone who has demonstrated themselves to be someone who can get breast cancer, am I increasing my risk of another breast cancer?
Mm-hmm.
So these are three separate risks that all have different levels of risk attached to them. Yet a person comes to clinic and says, well, what's my risk? So first of all, we have to articulate what is the risk that we're actually worried about. Because a risk of, it's never good to have a recurrence. That's hugely upsetting and distressing, but recurrences can often be successfully treated. So if a woman has a local recurrence in her breast, a mammogram picks that up, sure, that's going to be desperately upsetting and worrisome, but it is likely it's picked up on a mammogram, she has further successful surgery, and she will never die of that disease. So risk of recurrence is very different to risk of mortality, yet we talk about them in the same sense. So I think, first of all, we have to say, what is the risk that we are talking about? Once we've identified that risk, what are we actually talking about? What are we actually worried about? We then need to find the best data we can to understand that risk. And we do have models of doing that. So NHS Predict is a good model. It's a freely available software where people can input the pathological details of their tumour, and it will illustrate what is the risk of mortality over a 5, 10 or 15-year period. And the software also allows you to show what difference hormone therapy makes to that. So this is the anti-estrogen therapy, anti-breast cancer therapy, what difference that makes to their risk of dying of their cancer. There are other models that allow women to understand their risk of a recurrence once they've been on hormone therapy for 5 years, because some women may be they're having a pretty tough time with their letrozole therapy, but their doctor has suggested they may want to take it for an extra few years, and they're deciding, is this sensible for me? Your risk at 5 years is different to your risk at baseline because you've gone 5 years without a problem, a breast cancer problem. So you have now shown yourself, because sadly some women will have come into problems in that first 5 years. So your risk is different, and we can now estimate that. And there's a calculator called cts5.com where we can estimate what the risk of recurrence is over the next 5 years. So we can give some idea of baseline and have a sensible conversation about that. The problem we then have is, what multiplier do you put on that risk by the use of HRT?
Yeah.
So you will know, and many podcasters will know, that the best data we have is bad data. It's over 20 years old, the habit study, and the hazard ratio for HRT in that situation was somewhere around the order of a 3-fold increase in the risk of recurrence. Now, there are lots of arguments about that data, and we won't get into that here, but let's assume you accept that as a worst case scenario. What you were then able to say was, look, based on a CTS5 calculation, we estimate that your risk of breast cancer recurrences over the next 5 years is 4%. Habits would say, worst case scenario, we increase that by 3-fold, 12%. And then you can have an educated conversation about whether that person is willing to hold that risk in return for the benefits that HRT might bring them. And that feels to me like an adult to adult conversation, which is what we should be striving to achieve.
Me too. And it's actually the first time I have had the conversation where we can quantify that in a little bit of a way. That's a really good way of thinking about it. And if I wonder, you enabled a lot of doctors to have that conversation and to work it out, because everyone interprets statistics in a different way, isn't it, as well? Often people think, oh, I'm reducing my risk of a recurrence by 50%. But in truth, it might not be 50%. That's just what they heard or walked away from or picked up on, isn't it?
It's a great statistical trick. So, you double your chances of winning the lottery by buying 2 tickets. So people who are trying to so advertisers and drug companies make things sound good by quoting what they call the relative risk. So a 50% reduction in risk. What you as an individual, and that's about a population, but neither you or I are populations, we are individuals. So what we need to know is, what is our absolute risk? What is the risk to me? So if my risk of breast cancer over the next 10 years is 10%, and hormone therapy reduces this risk by 30%, by a third, the benefit of hormone therapy for me is 30% of 10%, which is only 3%. Sorry, that was a lot of maths at once, but
No,
you get the point. Yeah.
but that's so important, because people often say to us they didn't quite know how small the benefit for them was. And sometimes people say, I didn't know how big the benefit was for me. And I wish someone had explained that. And it's just really understanding that. And if you add HRT into that equation, it's just an addition to your risks and benefits, isn't it? And then we can all together as a patient, I always talk about the patient-doctor relationship and that team, and you work for us. I often say to the people, you get your GP working for you, they need to do a good job for your sort of healthcare team. And I think everyone together can achieve that by having that grown-up, non-judgmental and non-emotive. Of course, it's highly emotive because it's us, it's our life, and we so desperately depend on you guiding us on our choices. But if someone was really curious, that would be a very good model. So how, going back to where I interrupted you, and apologies again for that 5 minutes ago, going back to finding ways of having a register, what would that do? How could that help?
So a register has been proposed by the British Society of Endocrinology, Dr. Anis Mukherjee at the British Menopause Society also. And a registry, I think, has two major benefits. First of all, a doctor prescribing something that they know has risk is worried about the risk to that patient, but I'll be very frank and honest with you. They're also worried about their own reputation. What does that do to them? Are they viewed as a maverick? Do their colleagues say, Simcock over there is prescribing HRT after breast cancer? What's he like? And they're also worried that those patients may come to harm and that may come back on them in some way. So doctors are thinking of themselves to some degree. Let's be honest about that. But a registry allows them to show that what they are doing, they're doing in a diligent, compassionate, professional way. They're saying, we've had this conversation, we've thought about it carefully, we're going to take this step together to prescribe HRT. But in order to show that we've done this in a diligent, thoughtful way, we're going to register your details on a register. And I think that gives the prescriber perhaps the confidence that they need, that they're doing something in a responsible manner. The second benefit is that the person affected, the person having the HRT, is now contributing their data in a meaningful way so that over time that registry builds up and it contains enough evidence, to start to provide, hopefully, the reassurance that we need. Remember the habit study that we've been talking about, that everyone talks about, it's over 20 years old, only had 400 patients in it. So it doesn't take long to build up a database of a greater number of people that allows us to hopefully see safety signals that are reassuring. So I think there is a twofold benefit of registration. It holds the doctor's hand, makes them feel a bit more comfortable. And I know it's not about the doctor, but if the doctor isn't comfortable,
Yeah.
the patient isn't going to get what they need. And then secondly, that patient is doing something altruistic and helpful in knowing that their data is contributing to the global sum of knowledge. Because at the moment, a patient having a prescription has their prescription and their experience is their own, but it doesn't contribute to the global sum of knowledge, which is what we need right now.
And will this register also differentiate between the different types of HRT that are being prescribed? Because as a patient-led organization, we see it all. We have women that tell us about having pellets, testosterone pellets inserted in the UK when they are on aromatase inhibitors. We have women who are on tamoxifen or not tamoxifen who are on gel, testosterone gel alone. We know from people that are on systemic HRT, they've got a patch and progesterone, for example. There are so many different types. Will there be a way of differentiating between different types of cancer, different medication?
Yeah, exactly so. And the people involved in this, establishing this register are very sensitive to that issue. There's no point going to this effort, establishing this, if it's not going to provide those kinds of answers for us down the track. The more granular you make a database like that, the more information you put in, the more helpful it is. It does make it less pragmatic. So sometimes you ask big questions, HRT helpful, yes or no, so that's helpful, but it doesn't help you understand which HRT is. So getting those answers takes longer because you need more data points. So it takes you longer to get to the answers you might really want, but it's important work, so it needs to be done carefully.
And I'd know lots of people who'd be really up for being part of that, actually, who are already on a path somewhere and they're feeling quite on their own, quite unsupported. Yes, they have, of course, their relationship with their doctor, but I think they would like to be part of a bigger thing, really. Richard, you also mentioned a consensus statement and shared decision making. What's the difference there?
So the consensus statement is about healthcare professionals and experts coming together to find an area of consensus where we can build guidance that helps people understand what is best practice. Because as you well know, at the moment there are experts with different forms of expertise in different areas who will have different views about what looks like best practice. The more people that we can bring together that can agree in this complex Venn diagram, the bits where we all or have the best agreement, and produce a consensus guideline that people can share, the more likely that is to be followed and upheld. So at the moment we have guidance from the American Society, from the British Menopause Society, from internal individual trusts, or hospitals may have their own guidance. If we can bring that together and find the areas of shared agreement and build that into a consensus guideline, that helps people move forward. Now, that a consensus guideline will never be absolutely didactic. It will never say must do this, must never do that. It's more likely to say these, consider this, consider this. It will be a flow chart to say try this first, try this next, consider this. But it provides a space for people to explore what the best options are. And we're working through that process with breast cancer experts, British Menopause Society, endocrinologists, through a process called the Delphic consensus process, where the process gives these experts pen portraits of people at different levels of breast cancer experience, different stages and grades of breast cancer, different time points, and ask them to say how would they treat that patient, and what would they advise, and assessing their levels of confidence. And by going through iterating that process several times, we're able to find the places where people have confidence and explore the areas where people have less confidence that we can build up. So that's a work in progress. And when we get there, I'll be very happy to come and talk to you about it. The shared decision-making process is much more about the individual affected and their clinical team coming together, as I said before, in an adult-to-adult conversation. Now, shared decision making is often assisted by something called a PDA, a patient decision aid, something that often a visual representation of risk that allows a person to quantify, because we've just talked about how difficult it is to understand risk, the difference between absolute risk and relative risk. Patient decision aids allow you to graphically represent risk, and often the best way of doing that is something called a 100-person diagram. So these are little illustrations with 100 people, and you could use a 100-person diagram and say, well, if I treated 100 patients like you, I would expect this many, hopefully a small number, to be at risk of recurrence. And if I treated the same number with HRT, I might expect this number, excess, to possibly have problems related to breast cancer. But I'd also expect this number to have improved symptoms of X, Y, and Z. So working through a patient decision aid is one of the purposes of shared, but the true purpose of shared decision making is both of the adults in that conversation have been able to express their knowledge, their fears and their anxieties, and come together at a point where they've had a consensus between them. And that for me feels like modern medicine, and it feels an appropriate sharing of the risk.
In talking to you, it feels like to me, you guys, the medical professionals, you have come a long way. I've been in this breast cancer space as a patient over 11 years now, and very personally, very interested in the HRT conversation because of my own early onset menopause, and because of everything that is happening out there. You can't escape it. You can't escape people going, HRT is amazing and you'll feel awful if you've got a surgically onset menopause. And it's so important to know that as a woman, so you can't escape it. When I hear you speak, I feel like you've come a long way in trying to figure out what we do with not knowing much, because all I can hear from all of you always is, well, we don't know, the evidence we have is not very good, it's very old, it's, and all of that. Does it feel to you you've come a long way, or are you on the right track in helping us use the poor information, or whatever you call it, and use it for our generation? How do you feel where you're at right now in this time?
I think the door was shut, and the door is starting to open. I don't think it's fully open yet. It's part of the
No.
process I was just talking to you about. We did a survey of breast cancer specialists last year,
Mm.
asking them about their attitudes towards prescribing HRT. And in some of the scenarios we shared with them, I was absolutely expecting 100% no, I would not prescribe HRT. And the fact that actually in most of those scenarios, people were prepared to consider it. Now, considering it doesn't mean that they would do it, but consider it, felt to me like a really important sea change in the way that oncologists were starting to think about this. And that's because of the change we've seen in understanding the risk of HRT in causing breast cancer, but also the advocacy work done by yourselves and others to make it open our eyes to the extent of this problem. Um, and so it's an unmet need, and we can't just keep saying, well, we haven't got the evidence. We have to seek to do the best with what we've got. And I think there is enough there to move things forward. The evidence, I don't think, will ever be as good as we would absolutely want it to be, but there is evidence there that can help us move the conversations forward. And I am optimistic that the door is opening and people are willing to have these conversations in a way they may not have had even a decade ago.
Mm. And I'm not sure if we recorded this bit or if this was in our pre-recording conversation, but you spoke to me about advances of breast cancer treatment and where new breast cancer treatments are going. And I wonder if we're having this conversation about HRT after breast cancer, for example, now, but if breast cancer treatments would change maybe, and other newer treatments might not make us feel so miserable
Yeah,
and come with so many side effects that maybe we wouldn't even have to go and embark on a risque, perhaps, conversation of having HRT after cancer, if there might be other options to treat the cancer in the first place.
no, exactly right. So there are a number of directions of travel. You will know that there are some developments in treatments for symptoms. So the neurokinin agonists are interesting, and there is a large trial going on at the moment using these are drugs that appear to be exceptionally effective at switching off hot flushes. So it's just one aspect of a menopause, but a really important one.
Yeah.
They seem to be very effective at switching off hot flushes, and there is currently an ongoing trial specifically for women affected by breast cancer to see if that would be effective in that group. And I don't see any biologically plausible reason why that wouldn't be a successful trial. So watch that space. The problem with that, though, and I did say this before, for a lot of my patients, I really worry that we just turn them into the little old woman who swallowed a fly. That here's a drug, and now here's another drug to deal with the side effects of the drug that we gave you before. So developing medications to help with side effects doesn't seem to me to be the most elegant solution. The most elegant solution is to design drugs that have fewer side effects in the first place. And there
Yeah.
is some interesting development now in what are called selective estrogen receptor degraders. There is a there is a breast cancer treatment called fulvestrant, which is injected into your bottom rather than taken as a tablet. There are obvious disadvantages to that, having to have an injection in your bottom every month. But fulvestrant does come with fewer side effects, menopausal type side effects than aromatase inhibitors. And there are now oral versions of fulvestrant in development, called the oral SERDs. And there's currently a large trial running called the Cambria study, where women who are in the midst of aromatase inhibitor therapy, but finding that difficult because of side effects, are being offered randomization into the Cambria study, where they'll try these new drugs, which we hope will give them the same protection against breast cancer, but with fewer side effects. So those are studies that may bring useful data to us in years rather than in decades.
That's so exciting. That's really exciting, isn't it? Because it's just helping us to feel that there is stuff out there on the horizon. I know when we spoke to Professor Dillo, who was one of the scientists to work on the fezolinetant, isn't it, the non-hormonal drug for hot flushes, and we got him on the podcast. That was a couple of years ago. It was so exciting. It wasn't even in reach for us, but we just knew someone is thinking about us and the bigger picture, and there is hope and there will be change. And sometimes that's good enough to know as a patient. Um, I'm going to let you go. Be brilliant, Richard, because you've given us loads of time. And I have heard you are such an incredible oncologist from some of the people in our network. And I want to thank you on behalf of all of them for just being an amazing oncologist and also very forward thinking. So thank you for having this chat with me.
Yeah, and thank you for all your advocacy and awareness raising work. It's by having this dialogue between patients and professionals that we move everything forward. So thank you.
Yeah, great. Can't wait to see where the journey unfolds and for you to keep us posted on all of your developments, please.
Will do. Thank you.
Thank you. I hope you found this episode with Professor Richard Simcock really, really useful. It's a short episode, but I feel it's jam-packed with really great advice and so many important pieces that we need to understand to truly understand the bigger picture of why it is really difficult to move forward with this HRT after breast cancer question. I think it's key and crucial to also understand the practitioners, the doctors' sides of thinking, because as patients, we get very much wrapped up in our own thoughts, in our own thought processes. And so I thought it was really interesting to listen to Professor Simcock explain to us what some of the reservations and worries are from healthcare professionals, from oncologists who might consider prescribing HRT for those affected by breast cancer. I also thought it was really hopeful to know that there are new trials going on for medication that is a little bit similar to aromatase inhibitors, but comes perhaps with fewer side effects. I thought that was really hopeful. And in general, it's just brilliant to have this conversation so that we don't have to sit alone at home with our worries, with our fears, with our questions, not knowing where to go. And that is exactly the reason why I wanted to open this conversation. May it be conflicting, or may we have conflicting evidence, may we have a really emotive, controversial subject here, but I always think it's better to talk about it than not. So how do we move forward? On our next episode, I'm really excited to bring to you a doctor and a patient who has decided to go on hormone replacement therapy after her estrogen positive breast cancer diagnosis. And she's a true women's health specialist. She's really a pioneer of women's health. And I'm very excited to introduce you to her on our next episode. She's Dr. Tina Pearce. I'll tell you more about her on the next show. But before I do so, I wanted to remind you again to really tune into yourself. Are these conversations helpful for you at the moment? Do they come at the right time? Or are these conversations more anxiety inducing? Do you worry more about things after listening to these conversations at the moment? Because then please give yourself the permission to step back. You can always come back and reconnect with these conversations and the whole idea of HRT after breast cancer at another time, at a later stage. We're always going to be here. The conversations are going to be saved for you. I understand this is really difficult. As a breast cancer survivor myself for over 10 years, I've had so many ebbs and flow where my anxiety was super high, where I was so worried about my future health, where I was so concerned about the choices I was making, but also the choices I wasn't making. And so I totally understand and really want to give you the permission to step away from these conversations. I know many people want to have them. They want to have these conversations. And I know for many people, these conversations will never be right. It'll never feel that you could even go there, even in your thoughts. And so step away. Then the conversation isn't for you at this time. And maybe it's never for you. And I think that's really, really important to honor. So with that, thank you for listening today. I see you on the next episode of our HRT After Breast Cancer series. I'm Danny Binnington. I'm the host on the Menopause and Cancer podcast. And do also look at all of our menopause and cancer resources. As a not-for-profit organization, we provide so much advice, and really most of our advice focuses on all of the non-hormonal options, from complementary therapies to prescribable options. So tune into those. They might be really helpful for you right now.